Hi, this is Elliot Fishman, and welcome to part 2 of our evaluation of the abdominal aorta and its branch vessels. Last time we finished speaking about the SMA, and I promised I would give you a little bit more information. And the SMA, there's lots of pathology that involves the SMA. We spoke about SMA syndrome. We spoke about SMA embolic phenomena with occlusion and result in ischemia. But the SMA is so important because of the vital blood supply it provides to the midgut, and an acute abnormality can precipitate bowel ischemia, infarction, and have morbidity and mortality. We talk about vascular diseases from rupture to pseudoaneurysms to vasculitis, and the SMA is something that becomes very important across a range of issues, but especially in the ER setting. And this was an article we talked about CT angiography of the SMA in the ER setting, talking about things like SMA dissection, which is somewhat rare. It's not uncommon for us to see aortic dissections which extend into the SMA, though isolated SMA is uncommon. When it does occur, it's more common in males, age 50 to 70. Entry point typically will be a little bit distal to the origin, averaging a bit under 3 centimeters, and symptoms range from abdominal pain to nausea and vomiting to bloody stools, or it may just be an incidental finding. You can see hypertension, connective tissue disorders, vasculitis, atherosclerosis, and occasionally trauma are all possibilities. Now, in terms of what needs management, dissection obviously is one of the most critical. What exactly needs to be done? Is there true lumen compression that will lead to ischemia? We talk about therapy from medical to surgical to endovascular approaches. Again, we may try to do some conservative management, but that typically is not going to be the case, depending on how extensive it is. If you have a dissection and you have changes of ischemic bowel, you obviously are going to be more aggressive. Stent placement can be done, but it really depends on the patient's clinical symptoms. Now, sometimes, of course, we pick up incidental findings, and that's a bit easier. But once you have things like ischemia or suspected ischemia, people are going to be much more aggressive. Here's a nice example with multiple views on the axial and sagittal and on the 3D of SMA dissection in this patient who presented with back pain where the thought was an acute aortic dissection, but it was really, yes, there was an aortic dissection, but the key thing was the SMA dissection. Here you can see the extent of another patient with Marfan's, where the SMA dissection begins within 2 centimeters of the SMA origin, but you can see the extent of the dissection that's present. Or in this example, where there's SMA dissection, and then beyond the dissection, we see SMA occlusion, and again, this presents with back pain and likely would lead to potential ischemia if not aggressively managed, so this patient will be going to surgery. We talk about vasculitis, and I'm going to show you some examples of vasculitis over the next part 2 and part 3 of this talk. But SMA is often involved with vasculitis. It depends. Things like lupus can cause problems. Takayasu's aortitis is something we think about. It can involve the SMA. We talk about giant cell arteritis. We even talk about polyarteritis nodosa. So many different forms of vasculitis can involve the SMA. And again, when you're looking at the SMA and you see some pathology, you want to look at the other vessels from the celiac to the renal arteries to the aorta and additional branch vessels. You want to look at everything from the hepatic artery to splenic artery very carefully. And the same thing is, if you see something in the hepatic artery suggesting vasculitis, you want to make sure you carefully look at the renals, the SMA, and everything else. Now, in terms of treatment of vasculitis, stenting is uncommon. Patients will often be treated with different medications. A coil embolization is preferred for aneurysms, depending on their location, their size, and their neck. Here's a nice example of vasculitis. One of the key things you see on the image on your left with Takayasu's, the vessel is small in caliber and there's wall thickening. Image on your right, giant cell arteritis. The vessel is not as narrowed as on the left, but it is somewhat narrowed, and you see the soft tissue thickening around the vessel. It kind of looks like plaque perhaps, but it's surrounding the vessel, and that's a very nice look for vasculitis. This patient has, when you start looking carefully, aneurysms in the renal arteries, which are a bit harder to see here. This is the mesenteric vessels, but look at these branches off the SMA that have multiple aneurysms, aneurysms off the splenic artery, aneurysms off other branches of the patient's SMA as well. And look at the patient's kidney. So a patient with extensive renal aneurysms like this, really the only thing you could think about is polyarteritis nodosa, and that often involves multiple vascular territories, as you see very nicely in this case. Now, another thing that we see that can be somewhat difficult to diagnose and treat and looks often like a dissection is SAM, or segmental arterial mediolysis. It's a non-atherosclerotic, non-inflammatory disease, typically middle-aged patients, slight male dominance in this regard. The main differential diagnosis include FMD, but FMD tends to show more beating, and patients are usually asymptomatic, and it's a different age population. Here's a nice example of what looks first like a dissection. Then you follow the vessel downward. You can see irregularity of the SMA. Look at the beating and irregularity. Look at the narrowing here, areas of slight occlusion, all sorts of irregularity. I think the one thing you think about here is vasculitis, but with the SMA, this was SAM. Again, very nicely shown on the cinematic renderings. Look at the branches, particularly right here, how the caliber of the SMA changes, which is good for SAM, and the multiple areas of narrowing, very nicely shown again on a range of cinematic renderings. In terms of SAM, patients will often be treated conservatively. Again, the diagnosis, the differential is vasculitis, polyarteritis nodosa, perhaps, as well as dissection when you do see it. But again, it's some sort of vascular process, which is SAM. Now, we spoke about, and I showed you a case of a renal artery aneurysm or multiple aneurysms with PAN. We looked at a few SMA aneurysms. When you talk about visceral artery aneurysms, the splenic artery is the most common, makes up about 60 to 70%. We routinely see splenic artery aneurysms. They're often small, more common in women, particularly who've had multiple childbirth. With splenic artery aneurysms, you can also see other aneurysms, be it celiac or SMA. So again, when I see splenic artery aneurysms, I look at all the other vessels. But the truth is, you need to look at all the vessels all the time anyway. But once you see one aneurysm or one stenosis or one irregular process suggesting vasculitis, you really need to look carefully at everything else. Now, in terms of visceral artery aneurysms, atherosclerosis is the most common origin, though vasculitis, collagen vascular disease, FMD, and trauma are all potential causes. Multiple aneurysms, particularly in patients with connective tissue disease, is not going to be uncommon. Now, symptomatic aneurysms are also at high risk for rupture and should be treated whenever possible. Typically, we see a size decision. Most of the time, it's 2 centimeters. Aneurysms over 2 centimeters usually warrant therapy. As studies performed in patients with visceral artery aneurysms indicate that rupture is more likely when it's over 2 centimeters. When you have diffuse dense calcification, you're probably less likely to intervene because usually those patients typically will not have problems. So the splenic artery, we said, is number 1, about 70% of cases. It's defined as dilatation greater than 1 centimeter. Over 80% with splenic artery aneurysms are asymptomatic. Spontaneous rupture is the presenting complication in about 10% of cases, but again, it's usually dependent on size. Also, patients who have pancreatitis, which get an aneurysm, a pseudoaneurysm, because you can erode the vessel wall, those are going to be more likely to have complications. So in terms of splenic artery aneurysms, the usual suspects, atherosclerosis, top of the list, FMD, vasculitis, cirrhosis and portal hypertension, systemic hypertension, and atherosclerotic disease. We mentioned pseudoaneurysms, particularly with pancreatitis. It can be due to trauma or post-op complications or peptic ulcer disease, but pancreatitis is usually the main culprit. In terms of presentations, abdominal pain, melena, hematemesis, pseudoaneurysms are more likely to rupture with a high degree of fatality, and so these are treated much more aggressively. Here's a simple example of a 1 centimeter splenic artery aneurysm. Will probably be followed carefully. Here's a 2 centimeter in a patient with marked splenomegaly and portal hypertension. We often see these in patients who get liver transplants just because of the portal hypertension. Here you can see a nice example of a tortuous splenic artery with an aneurysm present near the hilum. Patients with markedly tortuous splenic arteries like this, if you look carefully, you often will see multiple tiny splenic artery aneurysms, but you're still going to treat the patient typically conservatively. As we mentioned previously, if you see one vessel involved, look carefully. This patient had a splenic artery aneurysm, but also had a GDA aneurysm. Here's a patient with rim calcification. Remember, we mentioned that patients with calcification, the lesions are substantially less likely to rupture, and so these patients are more likely going to be treated conservatively. Here you can see very nicely the rim calcification on the patient's MIP imaging. On the flip side, when your splenic artery aneurysm is roughly 5 centimeters, the propensity for these to rupture is high, and so in these cases, you'll either see resection or embolization. Typically, when it's this large, the coils are not going to work well, and the patient typically will go to surgery. And just a few more images using volume rendering, showing you very nicely the extent of that patient's 5 centimeter aneurysm. Now, we talk about certain syndromes that are more likely to get aneurysms. Ehlers-Danlos is one. It shows the patient has celiac artery aneurysms as well as multiple splenic artery aneurysms. So one of the things, of course, to remember is clinical history. If you have a patient with a disease, Ehlers-Danlos is one good example. Marfan's is another, where you're apt to get multiple aneurysms. You especially need to be careful. And here the cinematic rendering really nicely shows you the extent of those multiple splenic artery aneurysms. Here's a patient with left upper quadrant pain. It was worked up again for recurrent pancreatitis, but you can see the patient's pseudoaneurysm and this bleeding present. This eventually was embolized. The patient did fine. Once you see stranding like that, you realize the patient probably is bleeding, though not actively bleeding. We don't see an active bleed, but this needs aggressive management. It's not one of those cases you simply will follow up. Really aggressive splenic artery pseudoaneurysm secondary to repeated episodes of pancreatitis. Remember, patients with repeated episodes of pancreatitis with involvement particularly of the splenic tail, the extension goes to the pancreatic tail, it goes to the spleen, and so you can have splenic rupture due secondary to pancreatitis. So anything that involves the splenic artery or near the spleen and involves the pancreas is always going to be concerning. Another case, abdominal pain. When you look quickly, you look at the SMA, it looks okay, but arterial and venous, but what's that other structure? And when you look carefully and you do the reconstructions, you see the GDA, and the patient has at least 3 aneurysms in the GDA. One of the nice things about doing things like MIP or volume rendering, here's the MIP image, is because it's a projection technique, you really appreciate the aneurysms. Here, you see a little bit of dilatation of the patient's GDA. You got to think about things, but it's easy to walk past. When you have the full volume presentation, whether it's with volume rendering or just simply with MIP imaging, you recognize the multiple aneurysms that are present and how the patient will need to be treated. So just a really, really nice example of that. And here it is with volume rendering. So just a real nice example of a patient with SLE with multiple GDA aneurysms. Now, when we talk about and move over toward the kidney, we talk about the renal arteries. And renal arteries, there's lots of vascular processes: stenosis, AV malformations, aneurysms and pseudoaneurysms, often due to trauma, dissection, thrombosis, and vasculitis. And particularly some of the vasculitis, FMD is the most classic. And we published this article just literally a month or so ago, talking about the role of 3D imaging, particularly the role of cinematic rendering. We talk about how CT is the mainstay for the evaluation of suspected renal vascular disease, and there's a range of processes. You can often see them or appreciate them in part on the axial images or coronal views, but it's really the 3D imaging that makes it very, very practical. So let's look at a few of the things. Renal artery stenosis. Usually due to atherosclerosis, patients are hypertensive. You may get a CT to look for renal artery stenosis. Again, risk factors: increasing age, diabetes, aortic iliac disease, hypertension, coronary artery disease. Most of the time, the atherosclerotic changes in the proximal aspect of the vessel. We try to grade the stenosis and whether or not there's calcified or non-calcified plaque present. We'll describe other findings, including contralateral arterial involvement, other vessel involvement, and what's the general state of perfusion of the patient's kidney. Here's a patient with two right renal arteries. The lower right renal artery looks great. The upper one has a high-grade stenosis, and you also see about a 30% stenosis of the left renal artery. With renal artery stenosis and hypertension, stenting works well in most cases. It stabilizes renal failure, it improves hypertension, and reduces recurrent cardiac events such as pulmonary edema. And here's just a good example of stents in the patient's renal arteries as well as stents in the abdominal aorta. And the kidneys are a bit small, but with the stents, the patient does have good renal function. When we talk about vasculitis in the renal arteries, the number one thing we talk about is fibromuscular dysplasia. It can be a cause of renal artery stenosis. The classic finding is beading. It's more common in women than men, usually younger middle-aged women, and the lesions are often bilateral. The findings will vary. The classic is the string of beads appearance. You can see focal stenoses. You can see short or long stenoses. You could also see aneurysms. Rarely you can see dissection, and rarely is going to be thrombus. Rarely means I hardly ever will see that. In this article by Bolin, FMD is a vascular disease that results in stenosis, dissection, and aneurysm of nearly all arterial distributions, with the renal and extracranial carotid and vertebral arteries most commonly affected. So again, when we do rule out FMD, we're always getting a neck CT in my experience, and we also do the entire chest and abdomen to look for other areas. Again, clinical presentation: renal involvement presents with hypertension, and carotid involvement presents with pulsatile tinnitus. So again, what vessels are involved? And often multiple vessels are going to be involved. FMD is a diffuse arteriopathy. Again, it's medium-sized vessels, high prevalence of aortic aneurysm and dissection. Has been previously described with FMD, but I will admit I've seen only a few dissections. Most of what I see is the beading appearance. The other thing I see is areas of stenosis, and the other thing I see is evidence of aneurysms. So again, those are the things we talk about with FMD. Again, in our article, we made the point it's idiopathic, non-inflammatory, medium vessel disease. It is predominantly in females. And CTA, 100% sensitivity and 90% specificity. So again, a very, very good accuracy. You could read some of the other comments from the article. Here's just a couple cases. Right renal artery looks really good. At times, it's very hard to appreciate on the axials because you're always partial averaging. When you put things in volume rendering or you put things in MIP, you can see it very nicely. And in case 2, you can see there's 2 renal arteries, but only the uppermost renal artery on the right side is involved. Here's another example. Really nice beading of the patient's mid right renal artery. Another example here, extensive beating of the right renal artery. Left renal artery, if you did see it, would look pretty good. Another example, diffuse involvement of the right with subtle involvement of the left renal artery. I do like MIP imaging. If you get the bone out of the way, you can edit it or just slice with a volume, a cube that's under 10 millimeters. You typically can get a very good look at the renal artery alone, as shown here, very nicely defining the extent of disease. This patient was scanned for pheochromocytoma. The adrenals look good, but look at the patient's left hilum. There's a left renal artery aneurysm in the left hilum. The patient has beating in the contralateral renal artery. There's an aneurysm here. Findings that both go along with the diagnosis of fibromuscular dysplasia. If you only saw the renal artery on the left, you would say renal artery aneurysm, which can be due to a lot of causes. FMD is one of them, but unless I saw the beating on the right, I would not really be thinking and being very certain I'm dealing with FMD. Again, nice example of the volume rendering showing you that despite the aneurysm that's present, we have good function and perfusion of the patient's left kidney. And of course, the beating of the right kidney renal artery, be it with volume rendering or MIP imaging, is very nicely shown on those examples, and in this case as well. So you can see FMD is one of those things we need to think about. Another case with SMA involvement and right renal artery involvement. You can see the SMA here has beating present. A good rule with vasculitis is don't be happy you picked up one vessel. Keep looking. So the renals were easy. The SMA took a little bit more work to find the beating that's present there. And here's an unusual case of a patient with a prominent IMA, which has multiple aneurysms, and the patient also had renal artery involvement. So again, nicely shown on the volume rendering, the importance of looking at all vessels and how much easier it is to look at things within a volume to really appreciate, in this case, the IMA aneurysms that were present. And here I'm showing it to you in a number of different renderings. As I mentioned, patients with FMD will often have carotid artery involvement. So this patient had renal and carotid and SMA involvement, and the beating very nicely shown in this example of the patient's carotid artery up there. And then here's the SMA involvement. Again, it's not the entire vessel, but several centimeters really show you that beating very nicely. And again, it's not clear exactly what FMD really is and what is its source, but again, 2%, 3% of the population, and patients can be symptomatic. So again, very, very important, and we'll have more talk specifically on vasculitis, so I won't go into this any further. We mentioned, and I showed you some nice examples of renal artery aneurysms. Most common causes atherosclerotic changes, but right up there is fibromuscular dysplasia, and I showed you a few examples of that. Again, in terms of management, we talked about renal artery aneurysms being multiple, bilateral. Again, management is often size related, because the concern is when they get larger and they're not calcified, they can rupture or occlude. So the larger they are, the more likely there will be some intervention in that patient. Okay? The risk of rupture increases with pregnancy, patients with aneurysms associated with inflammatory etiologies, and then size related, here size being 3 centimeters. So again, very important. Painless hematuria from renal artery aneurysms is pretty rare. And again, the rupture is the main thing we worry about. And as the aneurysm gets larger, again, 2 or 3 centimeters, and pregnant patients, you really have to worry. Patients can have massive hemoperitoneum, and patients can die because you may not get control of the vessel and stop the bleeding in time. So when the aneurysms get larger, patients will be followed carefully, but often intervention, whether it's catheter or coiling or resection, will all be done. So again, very important finding. And here's just some nice examples. Here's a small aneurysm, left renal artery seen there. Here's a nice renal artery aneurysm with dense calcification. Again, we mentioned like with the splenic artery, when things are densely calcified, they're less likely to rupture, but it doesn't mean they can't. Again, just very nicely shown there. I mentioned before you can have multiple aneurysms, but it's only something like polyarteritis nodosa, where you look here, it looks like multiple stones or high-density structures, but then you look at the MIP, look how many aneurysms the patient has. I've never seen anything where you have 50 to 100 tiny aneurysms, but in polyarteritis nodosa. So let's do this. We've covered a lot. We've almost finished the renal artery. Let's do renal artery dissection when we come back. We'll cover a few other topics, and we'll do part 3, which is going to be our last part for today. See you in a few minutes. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.